Patient experiences during labor, birth, and postpartum can help identify obstetric racism in hospital settings. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Executive Speechwriter for AHA. Designed for, by, and with Black mothers and birthing professionals, the goal of the Sacred Birth Study is to test a new survey tool called a Patient-Reported Experience Measure of Obstetric Racism, also known as the PREM-OB Scale. The survey tool is designed to capture patient experiences of obstetric racism during hospital births in a COVID-19 pandemic. To learn more about this, Priya Bathija, Vice President of AHA's Strategic Initiatives, speaks with Dr. Karen Scott, Associate Professor, GYN Hospitalist, and Applied Epidemiologist. Dr. Scott is with the Department of Obstetrics, Gynecology, and Reproductive Sciences and Humanities and Social Sciences at the School of Medicine at the University of California, San Francisco.
Thank you, Tom. Dr. Scott, thank you for speaking with me today. I'm really excited to have this conversation, especially as we kick off Black Maternal Health Week. Can you just start by providing us a little bit of explanation around the purpose and an overview of the patient-reported experience measure of obstetric racism, which is also known as PREM-OB Scale for our listeners?
Yes, thank you so very much for this opportunity to share the amazing work we have curated and produced with community partners, with Black mothers and birthing people, with hospital partners and health plans. So the purpose of the patient-reported experience measure of obstetric racism, also known as the PREM-OB Scale, it is an instrument designed for, by, and with Black mothers and birthing people to be able to measure the impact of the quality of care on patient experiences when they seek help or health care for childbirth and they arrive in the hospital. And it allows us to capture the experiences of obstetric racism through their feelings, through their words, their perspectives across patient-identified quality of care domains. And that essentially means that we started with focus groups with Black mothers and birthing people and asked about their birth planning, their birth preparation, their birth expectation, and their birth experience, and grounded that in this explanatory framework of obstetric racism that was defined by Dr. Donna Ayin Davis, who is a Black feminist anthropologist and a doula. And obstetric racism sits at the intersections of obstetric violence and medical racism. And it describes these particular kinds of interactions, social and clinical interactions that occur between Black mothers and birthing people and their team, the clinicians, physicians, nurses, the staff, and the hospital system. And in these interactions, we really see the ways in which Black mothers and birth people's worth and value are degraded, dehumanized. Their reports of feeling symptoms and experiencing signs in their bodies get disregarded, dismissed, discarded is not of imminent concern. And then with that, we have these kind of subsequent things that occur, like delays in diagnoses or missed diagnoses, denial that we as Black people and birthing people experience pain. Black mothers and birthing people end up having to perform a certain way that makes hospital systems feel more comfortable about who they are as the system and how they relate to Black mothers and birthing people. So the first time we have a way to quantify, meaning translating the words and feelings into a number that a hospital can now rate their quality of care through this perspective of obstetric racism, and now be able to examine the associations of these kind of hospital benchmarks, such as low risk first-time cesarean births, preterm birth weight, low birth weight, NICU admissions, or transfers, because those are all numbers or quantitative data. With this scale, we can actually examine the associations between these birth outcomes and patient-reported experiences of obstetric racism, and really began to see how obstetric racism occurs within a system, within interactions, within counseling, within communication, within decision-making, and how that goes back to experiences of obstetric racism.
That's a big goal, and I know you are working towards it and have had some early findings from the work that you've done. Can you share some of those findings or any results or impact stories that you think would be helpful to show sort of how you're meeting those goals?
Yes, most definitely. So in 2020, we launched the Sacred Birth Study, and SACRED is an acronym for the different patient-identified quality of care domains in the scale. So for the first time, we're seeing safety and quality be defined and measured by the folks who are actually experiencing the care, and not a select group of data scientists, quality improvement experts, hospital clinicians, and administrators, where we continue to design and evaluate care with the exclusion or near erasure of the people most likely experiencing the burden, right, of death or near death, and also the benefit of equitable, ethical, and empathetic care. So we launched our study during a pandemic. There was no face-to-face interactions. We did all things in the digital virtual world, and we did it online. And we also met with community partners across the state and the nation. So in 2020, from the summer until January 2021, we were able to recruit and enroll 815 Black mothers and birthing people who gave birth in a hospital setting in the United States across 34 states and DC, and 348 hospitals. And with that, we also were able to bring on 17 hospital partners for the study across the United States. And being a hospital partner meant that you not only were dedicated to recruiting and supporting the referrals and enrollment of Black mothers and birthing people at your hospital into our study, but you also, it was an acknowledgement of recognizing that obstetric racism can occur in any system. It's not just what happens to the bodies and experiences of Black mothers and birthing people by white clinicians, staff, administrators. We recognize that obstetric racism really knows no face or skin color because of how we've been socialized and conditioned in this medical industrial complex, right? That race is something that's biological, or that Black mothers and birthing people are innately deficient or unfit to mother or to make appropriate decisions for their care for themselves and their child. So the 17 hospital partners not only supported referrals and recruitment, they also were able to participate in complimentary short-term technical assistant calls, where we shared the data of the study at the national level and their hospital-specific data across these domains. So SACRED, S, safety and accountability, also social capital and kinship. A is for autonomy. C is for communication and information exchange. R is for racism. E is for empathy and humanity. And D is for dignity and Blackness and holistic care. And so in our initial preliminary findings, we saw that we had, again, 815 Black mothers and birthing people. About 1 in 33, right, were married, 1 in 3 were married or living with a partner. About 1 in 4 are single, while also within that group of being single, about 15% were single living with their partner. So we felt it was very important to design a survey that reflected or contextualized the lived experiences of Black mothers and birthing people. And we knew that only looking at relationship status and not cohabitation status would limit the characterization of what it means to be Black and pregnant, birthing, and partnering in a pandemic. And we also asked about sexual orientation, gender identity. We asked about employment status and found that 1 in 2 Black mothers and birthing people were working 40 hours or more per week. About 1 in 8 were working about part-time, 20 hours per week. And then 1 in 15 were unemployed but looking for work. And that was also important to show the variations in employment experiences in our study. And then when we looked at the educational attainment, we saw that 1 in 4 Black mothers and birthing people had achieved a bachelor's degree, and 1 in 6 had achieved a master's degree. But when we look at the relationship between Black women's and birthing people's education and occupation, we were able to see this inequitable economic return on the investment for Black women's education and occupation. We were really informed and inspired by the work of Dr. Leith Mullins, an anthropologist who passed away, but we modeled our work after the Harlem Birth Project and not only incorporated obstetric racism as the framework to describe the problem and offer solutions, we also used the sojourner syndrome, which is a framework that looks at how oppression, such as racism, sexism, classism, impact the experiences of Black mothers and birthing people in the United States, but also those adverse experiences and outcomes in reproductive and perinatal care. And what we found that, again, in sharing again, if you can recall, I said 1 in 2 were working 40 hours or more, 1 in 4 had a bachelor's degree, 1 in 6 had a master's degree. But can you imagine our surprise and disappointment and really sadness that 1 in 3 households made less than $25,000. So we had a very educated group who worked full time, but the inequitable investment on their work and their labor and their education demonstrated that people were really living in substandard conditions, but were caring for themselves, many adults and children in the household. And just overall, we saw that when you design a survey that only looks at satisfaction, you'll only get a limited understanding of what's really happening, particularly in these interactions of counseling, communication, and decision-making. So although the majority of our study participants actually reported that their experience of care in labor, birth, and postpartum aligned with their expectation, we saw that kind of positive snapshot really disintegrate when we started asking, does your hospital include your lived experience as a Black woman in your care? The majority of people said rarely or never ever. We also asked, did the hospital provide images of hope and, let's say, joy, including Black mothers and birthing people and infants throughout the hallways? The majority of people said rarely ever or never did they experience that. We also asked a question around folks' reported understanding of the care that they received and all the procedures. And though the majority of people said they understood, when we assessed how their comprehension or understanding was evaluated, the majority of Black mothers and birthing people reported that rarely ever or never did anyone ask them to repeat back or write down what they understood about the care that was provided. So we saw many violations of people's autonomy, right? Being able to provide informed consent and refusal, violations of people's dignity, being able to feel that they are seen as a whole human being and not just a statistic grounded in pathology. We saw a lack of understanding both the historical and contemporary context, right, of getting pregnant, of partnering, of living, of birthing, parenting, and feeding your infant through the perspectives and experiences of Black mothers and birthing people.
So you touched on some of the findings that related to hospitals, but at a high level, what do you think hospitals can learn from this study that you've done?
Great question. I believe the lesson is that we need different measures. Having measures of quality and safety that are not grounded in kind of the ethos and ethics of equity, of racial justice, of gender justice, of intersectional oppressions, but also of resistance and resilience, that we need to bring community to the table, to the discussions from design to dissemination. And when I mean community, bringing those who the data shows carry the greatest burden of death and near death, but also recognizing and amplifying that the community also hold the solutions, right? And acknowledging and amplifying the power and potential of community to be able to examine the quality of care through their own experiences. And so I believe a patient-reported experience measure scale provides much more robust and responsive and relevant real-time data than the outcome of the rate of a cesarean birth in a low-risk population, right? And an example is one of the mothers and birthing people who had a full-term baby, so over 37 weeks, had a normal weight baby, had a vaginal birth, and the infant attached well, latched, and there was infant feeding through the body, breast chest feeding, and the infant did not require an admission to the neonatal intensive care unit. In that story, a hospital and a health plan and quality improvement entities will believe that's success because we met or exceeded our benchmarks. But we had a quote from one of our birthing mothers who said, "Though he put me back together, I still don't feel whole." And so we understand that if we were to only measure quality and safety through clinical or pathology outcomes or their absence of pathology, we really miss the fact that even with a good outcome, obstetric racism is still happening in the ways that undermine people's autonomy, that degrades their value and worth as a human being.
That makes sense. And it sort of dovetails into the next question that we had to talk about, which is moving forward, what do you wish the healthcare system would do differently to improve maternal health equity? I'm hearing you say we need to measure it differently. But outside of that, is there anything else that we can be doing to improve maternal health equity?
Yes, I think we really need to recognize and own the historical legacy of harm, right? Particularly in the field of obstetrics and gynecology, but also in midwifery, really in all disciplines that contribute to healthcare. And recognizing the history, I think we will also be held more accountable to bringing more voices to the table, not only the lived experiences of patients and the public, but also experts beyond data and quality improvement. What has really made this experience be so powerful and power activating for not only the scholars and the community, but it has been for hospitals seeing that the majority of our experts were in public health, in social sciences, in humanities, in legal studies. Like, how do we humanize the experience and realize that when hospitals focus exclusively on efficiency and efficacy, and at the loss of ethics and equity and empathy, that we are creating these very brutal and horrifying cultures of care because we continue to focus only on what the hospital needs as opposed to what the patients, the public, the families, and chosen and given family members that are in their circle of care. We continue to try to redesign something that excludes the very people who we're trying to serve. And so that's why I'm hoping that hospitals will begin to recognize the value of innate knowledge and power that exists in the community and in the public. And I also hope the hospitals and health plans begin to see value through a racial and gender justice lens and begin to link reimbursement of services to value that's based on a PREM-OB scale.
Dr. Scott, before we wrap up, I'm so thankful that we were able to have this conversation and I was able to learn more about what you're working on. But if a hospital wants to get involved and begin looking at this scale and how it can be incorporated into their day-to-day operations, what do they need to do?
Essentially need to contact us. I can be found through my email address, which I hope you'll share with folks. Also on social media, you can follow our program at sacred_prem_OB. And we actually will begin to launch a national sacred birth quality improvement, accountability, implementation, and scale-up plan, where we're looking for partnerships with community or safety net hospitals, a community-based partner that is led in serving Black women and people across the reproductive and perinatal lifespan. And if there are academic centers that are also interested, we are requiring academic centers partner with the safety net hospital or community hospital. And we want to build capacity and capability of hospitals to transform their culture of care, which means their delivery of care, the language, right, that they're utilizing to fill in the gap between the community's need and the fulfillment of that need when it comes to hospitalization for childbirth. And join the Sacred Birth Quality Improvement movement.
Well, I am looking forward to continuing our dialogue and this conversation on how we can improve maternal health outcomes. And thank you again, Dr. Scott, for being with us today. And for those that are listening, to learn more about the Sacred Birth Study, visit www.sacredbirth.ucsf.edu. And for AHA resources on maternal and child health, please visit www.aha.org. Thanks and have a great day.